Good afternoon, everyone. Welcome to the Berkshire Healthcare NHS Foundation Trust Annual General Meeting. I'm Martin Erica, the Chair of the Trust. This afternoon, the agenda is going to start with a presentation of the work of the governors by Brian Wilson, our lead governor, followed by a review of 23-24 by Julian Ems, the Chief Executive, and Paul Gray, the Chief Financial Officer. We'll then have a presentation on digital by design, showcasing some of the digital work we do, and a Q&A at the end to wrap up all the questions that you may have. You can submit questions at any time throughout the meeting using the chat function on Teams, and you can also do so anonymously if you wish by selecting that option. This will be recorded as a meeting and made available on our website afterwards, so those who aren't able to attend today can see the meeting. So let me start now by handing over to Brian Wilson, our lead governor, for the first presentation. Thank you.
Thank you very much, Martin. We have the opening slide. I'm Brian Wilson, lead governor on the Council of Governors. And the first slide I'd like to take you through is the composition of the Council of Governors. Next slide, please. As in previous years, we have a council made up of 32 governors. You'll see from the bottom bar below centre that the categories are public, local authorities, voluntary and other, and staff. This enables us to have a very good diversity of governors on the council, but also a very useful and very good diversity of experience across the spread of governors. The membership numbers are bottom left and right, public and staff. We have people leaving the trust who move area from time to time. We have new members joining, as that's something that can be done any day throughout the year. But these numbers have remained relatively stable and are much the same as last year. Next slide, please. Publicly elected governors cover the 6 boroughs, the 6 unitary authorities of Berkshire, and there are 3 governors for each of those 6 boroughs. Some of us are a little longer served than the others, but I'd like to congratulate myself, Madeline Diver, and Ros Crowder for being re-elected this June to our 2nd term of 3 years, and to welcome new governors as well, Hilary Doyle in Bracknell, George Matthew in Reading, Aryan Sharma in Slough, John Featherstone for the rest of England. You'll note from Windsor, Ascot and Maidenhead, and from Wokingham, that there is still a vacancy for 1 governor in each of those 2 constituencies. If there are residents of those areas, members in those areas who are on the AGM call today, and you'd like to take this further, on the last slide there will be contact details for you to express an interest in serving as a governor for those two areas. Next slide, please. We have 4 staff governors, 2 drawn from the clinical side of the trust and 2 from non-clinical areas. And again, we congratulate Guy Dakin for being re-elected to his next term of service as a governor. Staff governors are particularly important to us because they give us another view from the inside of the work of the trust. Next slide, please. I mentioned the 6 boroughs, the 6 unitary authorities. Each of those councils appoints one of its elected members, one of its councillors, to sit on our Council of Governors in the Trust. We have some new ones to welcome. West Berkshire, we have Councillor Patrick Clark. Reading Borough Council, we have Councillor Jacopo Lanzoni. And across the other side of the slide, under voluntary and other sector, we have Fiona Price of Age UK Berkshire. Welcome to all the new appointed governors. We look forward to working with you throughout the governor year. Could I have the next slide, please? We have continued with our same structure of meetings as we've had for the previous year. The formal council meetings at the top are open to the public and recordings are on the Trust website. Below that, the other set of formal council meetings will include discussions with the board executives and the non-executive directors of the trust, and there are 6 of those. And if you look at the bottom there, to question the board, part of the governor role is to be inquisitive, not just support and overwatch, but to be inquisitive and to seek assurance about the performance of the trust. And that's a very fundamental part of the governor role. You see on the right there the 4 key areas of our interest. There'll be more details of those with the 3 governor subcommittees on a later slide. Next slide, please. This slide gives you an idea of some of the areas of interest that we've been pursuing as a Council of Governors. We receive reports from parts of the trust. We also receive presentations from leading staff or practitioners in a number of the health service units. This helps the governors learn more about the trust's work and more able, therefore, to support, question and seek assurance about the performance of the trust. Next slide, please. Part of the role of the Council of Governors is to appoint non-executive directors. We can also, as you see here, extend the terms of office of non-executive directors. They serve for a period of 3 years per session and a maximum number of years on top of that. What we do from a strategic point of view, and this is approved by the Council of Governors, is receive and discuss proposals to make extensions to the service of certain non-executive directors so that we don't impose too much change on the trust board at any one time. And that is a benefit to the performance of the trust board. There is, as mentioned there, a small subcommittee. It's called the Appointments and Remuneration Subcommittee. And this is a small select group from the Council of Governors, which looks at making recommendations to the Council for the rate of pay of NEDs and the chair, and also is involved in the appointments of new non-executive directors. Again, the full Council approves and ratifies those appointments and those changes as proposed by the Appointments and Remuneration Committee. Next slide, please. These are the 3 subcommittees that meet themselves 3 or 4 times a year. The Quality Assurance Group looks at a very, very large amount of data, NHS mandated data on patients and other things. The Membership and Engagement Group looks at our outreach to membership, and in particular, the main focus we have here, particularly for this year, is reaching out to underrepresented categories in the membership data. Now, that can be geographical or it can be human factors, but we're looking to increase membership a little in certain categories so that the whole membership is more representative and more able to work with the trust and provide more value to the trust in partnership. Living Life to the Full group is probably a very interesting one because this explores activities outside of the trust after discharge or in relation to discharge. A number of other organisations come into our meetings here and talk to us with presentations about the health and care work that they do that also contributes to the health and well-being of our patients. Next slide, please. The Council plays its part within this NHS Trust to help meet and face the challenges that are in our lives. Oversight on performance and ensuring the needs of patients, families and carers is at the forefront of what we try and do as a Council of Governors. And as I mentioned earlier, if you're interested in the work of the Council of Governors or even becoming a governor in Wokingham or Windsor, Ascot, Maidenhead, then there is an email address here for you to contact, and we'd love to hear from you. Thank you very much. I'd now like to hand over to Julian Ems, our Chief Executive.
Thank you very much. Good afternoon, everybody. I'm Julian Ems. I'm Chief Executive. I've got the enviable task of trying to summarise what was an extremely busy year. So this part of the meeting is a kind of statutory part of the meeting, and it's a review of the last 12 months. The last 12 months been the financial year, so April 2023 through to the end of March 2024. What I'm not trying to do is tell you everything that's in the annual report. So there's a huge amount of detail, particularly around our service transformations that we did, and I would, if you want to know more, encourage you to go to that. What I'm trying to do is give you a flavour of what we did. The first couple of slides are going to be quite quick on each, really, just to say who we are, remind people who we are, because the NHS is complicated. There are other organisations with Berkshire in the title, so we can just go to the next slide, please. So we are the provider of community mental health services across Berkshire, and in terms of what we do, 50% mental health care and 50% physical health care. In terms of the physical health care, it's the specialist stuff that's not done by the acute hospitals or the district general hospital, in our case, Frimley and the Royal Berkshire. And to say that the NHS organises itself along the lines of collaboration these days. If you go back a decade, now very much about collaborating and working together, and the way we organise ourselves now is called an integrated care system, and we're in two of those: Buckinghamshire, Oxfordshire and Berkshire West, which is quite large. So Berkshire West has the west of Berkshire in it, and Frimley, which is 70% East Berkshire plus a little bit of Hampshire and Surrey. And it's really about all those organisations, health, social care, voluntary sector, coming together to deliver the best health and social care. Next slide, please. Just a couple of weeks ago, Lord Darcy published a report on the state of the NHS, commissioned by the new Secretary of State for Health and Social Care, and he said some very, very powerful messages about where the NHS needs to be. And it feels quite an exciting time to be in Berkshire Healthcare, because the things that we do are very much what Darcy's saying is required in the future, particularly the left shift towards out of hospital, community-based, neighbourhood-based care. Our mission is to maximise independence and quality of life. We do provide acute care in mental health, but it has a very strong rehabilitative focus, and most of what we do exists in the community. And as a vision, our vision is to be a great place to get care and a great place to give care. Next slide, please. So I've talked about integrated care systems. We work very closely in those areas, and in particular, we work with other NHS trusts to improve care pathways. So we have really strong partnerships with Frimley, Royal Berkshire, Oxford Health and Surrey and Borders. And generally, I have to say, I've been in the NHS quite a while now. This sense of collaboration and coming together is really constructive. It is definitely the way to go. The challenge that we have often, though, is that actually the complicated architecture of the NHS means that senior executives, senior managers' time is often spent on quite a lot of, I would say, external meetings, of the impact of which can be variable. So I think we've got the right philosophical approach. Darcy also made a similar point, which is perhaps the structures and the way we run things could be a little bit slicker, and I would agree with that, having looked back at the last year. Next slide, please. We are blessed with a very stable leadership team at board level and below, and last year we said goodbye to an extremely important non-executive director, Mahmouda, who retired from the board. She'd made a very significant contribution over an extended period of time to the success of the organisation, but we were delighted to appoint a new non-executive director, Rebecca Burford. Rebecca works in commercial law, and again, we're lucky that we have a number of NEDs who are actively engaged in employment in other sectors and giving up their time to be a non-exec director, so getting the benefit of that. And I don't think that can be overstated as an attribute. Next slide, please. The start of last year, we undertook an external well-led review of the board. It's good practice to do that effectively. We obviously do some self-assessments. We're able to make some judgments about our own performance, as others do, the regulators, but this was a proactive engagement with an agency to look at the top level effectively about how the board was functioning, running, how we did things around here. And the review was helpful. it sort of concurred largely with our own identifications of strengths and areas for improvements. It made a number of suggestions, but most were minor. We tracked that through the course of this year in the board, and we've managed to implement those actions. On the back of that, we've updated our board assurance framework. Again, for many that might seem like jargon, but essentially, if our mission is to maximise independence and quality of life, and vision is to give a great place to get care and to give care, what are the risks to be achieving those things, and how are we going about managing those kind of key strategic risks? That's what the board assurance framework is, and we updated it and aligned it with our strategy and also the findings from the well-led review. So essentially it might seem like housekeeping or quite technical things, but ultimately making sure that the organisation is on track to perform as it should do and achieve those things that are really important to the population that we serve. Next slide, please. The NHS is the largest employer of people, and we're one of the largest employers of people in Berkshire. And so clearly workforce is really important. There's a direct correlation between high satisfaction and high degree of patient care. Research has nailed that on. And we had a target post-pandemic to reduce our turnover, the number of people leaving the organisation, from 16.5%, which is quite significant, down to 12%, and we've achieved that, and we're really pleased. So less people leaving the organisation, creating more stability in teams, less likely to have to use temporary staffing, such as agency. We've achieved high positive scores in the NHS staff survey, exceptionally high positive scores in staff engagement, and across the board, one of the highest in the country, and I'll just show you a slide that reinforces that. And at the same time, it's important to recognise some ongoing challenges. And for us, like a lot of the NHS, a lot of social care, there are a number of challenges, but a particular one is closing the gap in experience between minority ethnic staff and their white counterparts. We are pleased that we have made some inroads in that in terms of the way we measure it, whether it be in the staff survey or data in relation to disciplinaries or access to training. But still there is a gap. So excelling overall in the staff survey, we recognise there's more to do in that space. That's why we think it's a top priority and very much part of our plans this year, next year, and probably the year ahead as well. If we move to the next slide, it simply reinforces that point around the staff survey. So if you wanted to know the detail, the staff survey, the largest of its kind, evidence-based, and it's broken down into a number of compartments about effective team working, staff engagement, staff morale, etc., learning organisation, and we came top in a number of those and right at the upper quartile. So really pleased about that, but most of all, if I'm absolutely honest with you, what's most pleasing about it, it's the 5th year in a row that we've achieved those results, and it's that longevity that really is the issue. It's not much use achieving a high score next year and then dropping down the next. So that consistency of purpose in this area is the area that brings the board greatest satisfaction, in fact the workforce too. Thank you. Next slide, please. I suppose I'm the warm-up act really for the really interesting presentations that are about to follow, and that's particularly in the digital space. Again, sorry to labour this point, but Darcy in his report said, 3 important things. We've got to go from curing to prevention. We've got to shift care out of acute hospitals and into the community, and we've got to move from analogue to digital. I'm really pleased to say that in terms of digital rankings, Berkshire Healthcare is the top in the sector in terms of digital maturity. There's always more we can do. I think, people can often get lost in this world. I think real digital transformation is not about having loads of digital experts, but real digital transformation is about learning to become more adaptive to change itself. What does the world of tomorrow need? What can we bring about that will be meaningful in order to get there? How can digital help us get there? And so we've been a leader in this space. We're exceptionally lucky to have some fantastic technical expertise, but we have also developed a culture around digital first, whether that be online therapies, taking out routine tasks, which we'll hear a little bit more about. But actually, I think the opportunity to tackle some of the NHS's biggest problems is here for all to see. I was this morning with a group of leaders from another system who have just kind of transformed the way in which they plan their workforce demand and supply by using digital tools in a way that actually we've struggled to in the past. So whilst there's really big challenges for the NHS, as my colleagues will later show, there's real hope about the potential around digital, and I think we're in a really good place to exploit that. Next slide, please. One of the things that, if we were really critical and we looked at the presentations that we've done in AGMs in the past, you could say that actually we tended to treat our patients as a homogenous group. We hadn't necessarily started to understand the people we were serving and the differences there. And I think over the last few years, there's been a really significant focus on health inequalities, those unfair inequities that actually are, do not and should not exist. And I think across the organisation now, we've worked very hard with the high quality data we're starting to collect to identify unacceptable inequalities and start to tackle those so that we're actually achieving our objective of being a great place to get care and to give care. So that actually we're a great place for everybody, regardless of background. For example, we know across the country, nationally, there is an issue about black men being disproportionately sectioned under the Mental Health Act. And we've started to do work in our own area about looking at the systematic ways why that might be and starting to think about bringing about the changes that would reverse that trend and ultimately address that very stark health inequality that has existed for many years. I would say, if we're honest about it, there's massive enthusiasm, but probably we're at the foothills of what we're able to achieve. What I'm pleased about is with Martin and the board's support, there's definitely been a tilt and a cultural shift to understanding the importance of getting these health inequalities right. And when we do, that actually we offer far better care, and we're often able to offer the right type of care in a personalised, coordinated way. Next slide, please. The other challenge, I mean, you can't turn the television on, I suspect, so there's probably not going to be a huge amount I'm going to tell you that's new here, but I think we do have to acknowledge that we have some real challenges, not in all of our services, but in a number of our services around managing significant increase in patient demand. That's definitely been the case post-pandemic, but it was rising before the pandemic, let's be honest with you. It's right across the NHS. Some of the waits are unacceptably long. I don't like waiting that long. No one likes waiting that long. What we've had to do to make sure we make an impact is look at those waits that potentially are causing the biggest harm and do something about it. And we have been able to make some breakthroughs. There's no silver bullet, but the things we've done is really target our recruitment efforts where we have those biggest challenges, using digital where appropriate. Engaging and working with the independent sector or the private sector potentially to work through some of the waiting lists where there may be some additional capacity, and making sure that where it's relevant and appropriate, offering enhanced support and guidance for those who might be waiting a long time for assessment. I think my final slide is just a summary, please, by way of summarising the last financial year in terms of performance. We maintained our outstanding rating with the Care Quality Commission, the regulator of health and social care from quality standards. We've met our financial targets, which is very unusual. Paul will talk about the detail of that, but I would say that is very much the exception. Most trusts were in some kind of deficit, so I think that's the organisation should be rightfully proud of that. The excellent staff survey results, which I've covered off, and the efforts and collaboration that we've put into our integrated system, and also to some of the work we've done at a regional level, mean that in relative terms we've had a successful year and one that we are pleased with on the whole. So thank you. That's a whistle-stop tour of some of the key highlights of the year. As I say, if you want to know more, the annual report is the place, the repository, as well as the quality account as well, actually, which also tells you quite a lot about Berkshire Healthcare if you want to know a bit more. Another kind of statutory duty is to simply go through the finances in a little bit more detail. And I'm going to hand over to my colleague Paul, the Chief Finance Officer, to do that now. Good afternoon, Paul. I'll hand over to you now, and thank you.
Thank you, Julian. I can just have the first slide, please. We could get the next slide, please. Thank you. So good afternoon, everyone. So if we just think back to March, April 2023, we entered the financial year with high levels of patient demand following the pandemic, but we also had an extremely challenging economic climate, operating with higher levels of inflation than we'd historically seen. So in that context, the board agreed a planned surplus for the year of 1.3 million. This assumed that we would be able to deliver close to 14 million of efficiencies during the year. We plan to invest 12.5 million into our capital programme, and taking our planned surplus combined with the cash required to fund that capital programme, we expected to see a decrease of cash of around 8.7 million during the year. If I can just get the next slide, please. Thank you. In terms of our actual performance and what we delivered, as Julian alluded to, we had a really successful year. So we surpassed our planned surplus of 1.3 million and delivered an actual surplus of 3.8 million. It's worth noting that the 3.8 million surplus is after adjusting for the financial impact of some national changes in accounting treatments that we saw, particularly around our PFI assets and the asset impairments arising from our annual audited revaluations. The total impact of these was 10.3 million, but this value is excluded from the assessment of our financial performance by NHSE. In the table, you will see that we saw a significant increase in the trust's income during the year, so increase in income of 26.6 million. This is primarily the result of national price inflation funding, which we received through our NHS and other contracts. And in addition to that inflation funding, we received specific funding for the Mental Health Investment Standard, which is funding to recognise growth, particularly in mental health services. And we also received some specific service development funding, which is targeted at specific mental health and community health service initiatives during the year. Whilst income grew, you'll also note that we saw a notable increase in the cost base of the organisation, and our expenditure increased by 33 million. This is predominantly driven by national pay awards, so increasing salary costs, but also off the back of the investment income that we saw, we did manage to increase the workforce, and the workforce grew by about 250 during the course of the year, supported by some of that investment funding that we received. The final major contributing to the cost increase is the previously mentioned impact of the accounting standards. Overall, we aimed for and we delivered 14 million of efficiencies during the year, with particular note in terms of controlling spend on some of our area placements, reducing the cost of some of our property costs and lease spaces, and benefited from negotiated benefits on a number of contracts. From a capital perspective, we continue to utilise our cash reserves, and we managed to contain spend within the agreed limits that we set with Buckinghamshire, Oxford and Berkshire West ICS. We spent 10 million of our planned 12.5 million capital programme. Key difference being the timing on the completion of our new place of safety facility at Prospect Park Hospital, which will now complete in this financial year. Of the 10 million we did spend, 3.8 million was spent on our estate. So this includes a new facility called Resource House in Wokingham, which houses some of our community health services and is a replacement for a building that we moved out of in Wokingham called the Old Forge. Outside of this, we had a number of smaller upgrades and developments across the wider estate during the year, and we spent 6.2 million on IT equipment and improving our IT infrastructure, including increasing cyber security measures. Finally, we closed in a strong cash position. We closed with 52.6 million of cash, which was a smaller reduction than planned. So we only saw a 2.6 million reduction in cash during the course of the year. And importantly, we were able to submit our annual accounts ahead of the national deadline, and we received an unqualified audit opinion from our external auditors, Ernst & Young. And just take the next slide, please. Thank you. So moving forward and looking into the current financial year, I think fair to say that we're still operating in a challenging operational environment in terms of demand for services, and the financial environment is still very, very difficult for NHS organisations. In support of the wider BOB system, we've set ourselves a 1.9 million surplus plan for this current year, and that includes a similar level of efficiencies to what we delivered last financial year, so assumed efficiencies of about 13.6 million this year. Given our cash position, we're continuing to invest in our capital infrastructure, so we're planning to spend 13.1 million this year on a combination of our estate and IT infrastructure. And if we combine the surplus and level of investment that we want to make, we expect our cash reserves to decrease by 5.8 million during the course of this year. Thank you, and I'll hand over to Mark Davison, our Chief Information Officer.
Thanks, Paul. Good afternoon, everybody. As Paul said, my name is Mark Davison. I'm the CIO, so I'm responsible for the digital services within the trust. And could we just move to the next slide, please? Thank you. Back in 2021, the Trust Board agreed a digital strategy to match our service strategy. And principally, we were looking at three things. We were looking at how do we optimise how we work, joining up our digital tools, sharing our clinical records across primary and community and secondary care, in order to provide a safer environment for our patients and help our staff to deliver a more efficient service. We've been able to view primary care records for some time now, and we've recently extended this to enable GPs and social care to be able to see our written records and gain a clearer insight to a patient's current status. We've also been working on automating our processes and integrating data between the various clinical systems we need to use, which saves us time across our workforce and enables us to spend more time with our patients. We've some small-scale explorations in place this year to test the benefits of things like artificial intelligence in our healthcare processes, expanding on our work over the last year in utilising intelligent automation to speed things along and develop that more time to care. And John and Lisa and Lucy will cover some of this elements later on in the presentation. We've also, in the second objective was for empowering our patients. And patients will always have a choice with how they engage with us. And our digital solutions now offer a more personalised service and enable us to do some things it's very hard to do in person, such as language translations to 98 different languages, and the ability to provide often reminders to family and carers as well as the patient, and some proactive information to help patients maintain and improve their health between appointments and whilst waiting for appointments. We are fast approaching the time when our patients engage digitally with us over 500,000 times a year, And some of our digital services have been in place for a while, such as talking therapies that Julian mentioned, and digital therapeutic networks such as Sharon. And they're all expanding to new patients every year into new clinical areas, reaching more patients with more proactive and modernised treatments. Some of them are new, such as the provision of the Sleepio app to 15,000 patients last year who've associated sleep problems to go with their health needs and always need an available and accessible therapy to help them get a good night's rest. I'm sure we'll all agree, one of nature's most important health remedies. In December last year, we made a change in functionality to our digital appointments processes, making it easier for patients to use and more integrated with a services digital record system, making it easier for our staff to use. Even a modest adaptation like this creates a step change in how those services are used for patient communications and demonstrates the potential reach of these types of technologies. With our new patient engagement portal, which we purchased this year, over the coming months, we expect to create a similar setup, closing the gap between those that use that digital service and those that do not. Areas we plan to cover over the next 12 months include pre-consultation information and questionnaires, patient-initiated follow-up appointments rather than scheduled follow-up appointments, and ongoing advice and guidance for those with long-term conditions. In the longer term, this will shift the scheduled care focus from periodic appointments to patient and clinical monitored initiated follow-ups, saving resources and targeting those scarce resources we do have to those patients most in need. Our third area is to enable our people. Our staff work in a digital healthcare world, and we need to ensure that all of our workforce has access to the required tools and skills to help them deliver outstanding care to our patients. Some of the technical aspects of that include ensuring that they have the right device, that they can access those records from anywhere through high-speed modern networks, making sure that when those devices fail, which equipment often does, that it's replaced quickly, minimising the disruption to patients, scheduled services, and to our staff. We've made it safer and easier to use, limited the number of passwords, made sure that there's something called multi-factor authentication in the process to secure our data and our patients' personal information, to ensure that even in offline working, our staff are able to cope with the loss of data and there is no leakage of that information outside of our trusted staff. We've created a digital marketplace enabling our partners to interact with our patients, recognising that social care workers, voluntary sector care workers, and those in other areas of the health service are all part and parcel of our staff when it comes to seeing our patients. Making sure that we have that digital marketplace where we can share records safely, roster our staff, and ensure that communications work between those sectors is so vital to how we deliver patient care in a modern environment. Rostering our staff to help support them work as flexibly as possible has been digitised across our organisation in the last few years. And we're expanding the support of our shared care records by enabling other care sectors to access our narrative progress notes, such as GPs being able to see the current status of a mental health patient or a patient who might be in one of our community physical health hospitals. Other areas of the country also need to know someone who is under our treatment has access to their respect or recommended summary care plan for emergency care and treatment, or to their mental health safety plan. Linking these things up ensure that wherever in the country our patients are, they can be guaranteed the latest, that the staff dealing with them have the latest information about their healthcare status. But as well as that technical aspect in enabling our people, it's about people. 3,000 of our staff have now attended at least one module of our innovative digital skills training processes. We've developed and have active and vibrant development networks for digital clinical leaders, for digital clinical safety, digital skills across our workforce, and operational use of those digital tools. These all continue to grow and thrive in our organisation, which is fantastic from a point of view of embracing that digital by design ethos. Our digital health leadership programs give our senior staff and our developing career staff access to master's level knowledge and education in this new environment, as well as national peer networking and membership of professional bodies such as the British Computer Society and the CIRI National Network for Women in Digital. Online appraisal, learning and supervision is now a core part of our staff development programme, and digital healthcare is embedded in our service redesign and continuous quality improvement activities across the trust. As you can imagine, it's a challenge to go through all of this in a level of detail today, but John, Lisa and Lucy will now give you a view into how some examples of this are now supporting our care delivery. So I'd like to introduce John Burton, who's our Head of Intelligent Automation in the Trust.
Hello, everybody. If I can just get the next slide, thank you. You can go to the next slide, please, Jade. Within Berkshire Healthcare, I'm responsible for something that's called intelligent automation, which when you actually break it down is effectively just a fancy name for robotics. Now, these aren't physical robots, so they're not going to be whizzing up and down wards and people skipping out of the way in corridors. These are software programs that have a life up in the cloud, so they don't live on in buildings on physical computers as such, but that doesn't mean they're not clever. So these software programs are more than capable of doing tasks that we find Berkshire Healthcare people are doing repetitively. So the whole function of robotics or automation in this program is to free up time, to have hours of work done through automation rather than humans having to do it. And then there's a whole piece of work around how that freed up time, because we've got clinicians not having to do repetitive work quite so much, and that is then readjusted back into patient care. So, you know, the key takeouts of it really are, we're taking away the grind, the routine stuff. If a robot can do it, we don't want people doing it necessarily. They can focus on improved patient care or delivering more time into patient care. And also, it empowers professionals. You know, you don't go through medical school necessarily to do that kind of routine work, especially if we have the technology now to have robots pick it up and do it for you. And there's a real life example there, you know, 304 hours, it's just one robot. You'll see how many we've actually got running. It's an immature program, really. It's only become formal since April this year, although it did have a proof of concept a year before that. So it's moving fast, and you know, we're winning the battle of delivering automation, and we've got a fair number in. And just that one example, for 304 working days returned where people aren't doing stuff robots are. Next slide, please, Jade. So what are we doing? What are we actually automating? Well, pretty much anything and everything where there is a need. There is a process which we'll see in a minute, but along with you know, the obvious things like discharge, referral, etc. You know, staying in contact with our patients better, because people don't have to remember to text message or to email reminders out to patients. The robots do that. We've had great wins in HR, our time to hire. One of the best we've had for a long time, a 10-day reduction in the time to hire period from pre-automation to delivering automation. We've only delivered 2 into HR that are significant for that, but you know, reducing that time to hire is a big win, obviously. And then one of the forgotten things about robotics is if you live in a world where you buy non-integrated systems, which has been the NHS for a long time, I mean, getting better at it. System A you buy to do the job over in that corner, and system B you buy to do the job in the opposite corner, were designed completely separately, had different different design aspects. They were designed to do different things, never to talk to each other. But actually, in today's world, goodness me, it would be really useful if they did. And the cost of designing systems to connect those two are huge. But using software robots who can use the user screen on system 1, take the information out, store it safely, and then move it through the user screens on system 2 are hugely beneficial. And we're really only just starting to open the doors on the potential of that. Next slide, please. So where have we got to? These are just numbers, and you're going to hear a real conversation, or be party to a real conversation in a minute, from somebody who has had a robot in their service, one of the first services to have it. But these are the numbers. We have 41 robots. I still now think, where did they come from? 17 in build. We've got over 100 ideas that have come in from the good folk that I work with. This is seen really positively within the organisation. And we see that reflected in the number of calls we get literally on a weekly basis from people saying, oh, could you do this? Could you do that? We can't deliver them all, not as quickly as I would want, but we're ploughing our way through them. And the key metrics to take out of this are the robots do things generally 50% quicker than people, unsurprisingly, I guess. And that will only get quicker as we get cleverer and the robotics gets cleverer, get cleverer. And on top of that, of course, they do it all day, every day. So we don't have to worry about weekends. And I heard a great story today about a service who used to dread bank holidays, especially long bank holidays, because of the workload they would come back to on the Monday. And we put a robot in, and the feedback we've had is transformative. It's just amazing. It's transformed that service. All that stress has gone away. It's improved efficiency in so many ways that we just really didn't imagine until we started getting real life intelligence back from these things. And of course, generally I said they work 24 hours a day. They generally don't need holidays, but they do occasionally go sick. They get ill occasionally. We have to pull the plug out and put it back in again. But we're at nearly an 80% uptime without these things breaking. So when we build them well, and they're efficient and they stay up, which is obviously important. We don't want our robots offline. We don't want to spend more time fixing broken robots than we do watching them work. So next slide, please, Jade. So I'm going to hand over to Lisa. Lisa will introduce herself. Other than me saying she's one of the first people in the trust to receive a robot.
Hi, so I'm Miss Buxton, and it's my great pleasure to manage the Wokingham Health Visiting Team. So when we were newly commissioned back in 2022, one of the additions to our commissioning was that we have a 3 and 6 month contact with patients and clients in the community. And I approached the IA team at this point and asked if this was something that they could help us with. We already had administrative teams that were under pressure, teams that were under pressure. So we were looking for this to go another way, and we were really fortunate that it was picked up, and they supported us with this. The team were brilliant. There's no way that we could have done it without them, obviously. And we were novices, but they guided us through it, and they were really supportive of the work that we were doing. And we managed to open this up so that it was across Wokingham, West Berks, Reading and Bracknell. So when I first submitted the application, it was really to take some pressure off already stressed and pressurised administration staff, and the robot would come in and send this digital contact out, and we would save money in admin hours. We would save admin having to do that. And we worked out that this was approximately 10 hours just in Wokingham per month that it was saving. but it actually became quite a lot more than that, because that then started a domino effect. We started to look at other ways we could then start to work smarter. We certainly couldn't work any harder. The team that I manage, I could not ask them to work any harder, but what we could do is we could really start to look at how we could work smarter. And that's what we started to do. So we were able to ease the vacancy problems that we had, and support each other across the localities a lot better. We looked at streamlining other processes that we do, so that created additional time. It added to our the fact that we wanted to decrease our carbon footprint, make us more green. So we were able to have a hand in that as well. And we were able to free up time so that we could add to clinics, create more clinic slots, see patients through the children's centres where we do now, support them more in breastfeeding journeys and any support that we needed to give them around behaviour or eating or anything like that. We also used redistributed staff, if you like, so that they were actually able to support health visitors where we also had a vacancy, and this managed to support the health visitors in some of the tasks that they were doing, which lessened the detrimental impact that we had, and that vacancies can have in a team. It positively influenced our KPIs, so we were actually managing to reach further towards the KPIs that we were striving to reach, because we were able to get in earlier, because the admin teams were able to get in earlier, book appointments, and then if parents couldn't make it, we still had that time to book in and see them within sometimes a very narrow time slot that we have to see parents that come with the mandated contacts. So we were also able to have a look at how we look at our data and be more consistent with checking our data, synchronizing records, keeping demographics up to date. So this ensures that the information that we hold is the best that it can be at the time for the families that we have. And we're able to monitor that through the exception emails that we receive back from the robot. And this has gone down considerably to a point where I can say that in the last draw that we did, I think we had 2 exception emails, which is phenomenal across the locality. There was also a sense of pride, I think, in having Robot L and seeing Robot L in some of the records, particularly for us that had worked on the project, and we felt it. We were going towards a more digital client, and reaching out to some of those clients that are more digitally based than we were at the time, and I think that was professionally that was more kudos for us. There's been loads of benefits, and moving forward, I think the benefits that will just keep increasing and coming to a point where we can now start looking at a new birth pack that we want to put digitally, that we will then look at, maybe the robot can support us with sending that. This will further reduce our carbon footprint, make us more greener, save those trees, and we can just keep pushing forwards with this. If it wasn't for the IA team and this automation, then it would have been a lot different a story. So thank you, and thank you for listening.
Hello, and my name's Lucy, and I'm the lead for the Berkshire East Heart Function Service. And thank you for having me this afternoon. Next slide, please. So I'm just going to go through how we remotely monitor our patients on our virtual heart function ward. We decided to do this because we were very lucky enough to be chosen by NHS England to become one of their pilot sites. And we wanted to have real-time remote monitoring for our heart function patients. Now, all patients that have decided to be monitored with our team get given either a care portal, or they use their own mobile and tablet or their own computer. They download an app from the App Store, and then they are given by us a blood pressure machine, an SpO2 machine, and some scales. This can be started in the acute trust, so up in Wexham or Frimley, then gets handed down to the heart function service. And then as the patient gets better, we can then hand them down to a remote monitoring service. They have fully customised question sets that are written by the heart function service, and they monitor their observations on a daily basis. It also has a messaging service so that they can message us at any time they want to if they've got a question. And it has information on conditions and self-monitoring advice and something called the heart function traffic lights. All this information is also linked with connected care. So anything we do, the GPs can see it and they can see how their patients are being monitored. This is to empower our patients to know their numbers, know when they're getting sicker, and to alert more quickly. Next slide, please. So why did we do it? Heart failure is one of those real, where they call it the Cinderella syndrome. This accounts for 5% of emergency hospital admissions, 1 million inpatient bed days, and 1.8% of the NHS costs. And that's mostly due to direct hospitalisation, where a lot of these sort of hospitalisations can be avoided. So we needed this so we could detect any early decompensation in their symptoms, hopefully reduce the length of stay in hospitals by 50%. They can get them out quicker if we're monitoring them more closely. Reduce hospital admissions by 15%. Better self-management. Reduce any clinic appointments and home visits. Increase our nurse capacity. It's a way of working differently. Quicker up titration of evidence-based medications. Heart function patients should be on 4 pillars of heart failure medication. And the idea is to get those medications all in within 4 weeks and up to maximum titrated doses within 3 months. Access to IV diuretics in clinics and at home. So if they are deteriorating, we are able to give them IV diuresis in their homes to reduce hospital admissions. Our better integration between primary and secondary care. They can hand down and we can hand up if patients are deteriorating, and to improve our patients' experience. Next slide, please. So we wrote our own standard sort of SOP of how we wanted to work it. We decided where we wanted to take patients from. There are over 7,000 heart function patients in East Berkshire, and we would like to get them all monitored if possible. You can go on to the next slide, please. So hopefully this video will work and it will show you how it works for our patients. They go onto an app every day. Oh, it's disappeared on me. They go onto an app every day and it asks them to choose whether they're feeling more short of breath today, more swollen, coughing, and they have to say yes or no. They then put their blood pressure, pulse and SpO2 in, and then that gets whizzied somewhere ether-wise, I don't know how it works, to my laptop where I can have a look at it. I don't know if that's working for you, but hopefully you can always come and have a look. At the bottom, it has an anytime button. So if patients are feeling unwell, they can just do a set of questions and that will get alerted to me. And there's also an information button on there which has all sorts of information about their condition, the medications they're on, the heart function traffic lights, which is a red, amber, green traffic light of, you know, when to get help and when to call for help. So this is how it works there. So hopefully you can see that now. It is an easy system to use. At the moment, our youngest patient is transitioning from paediatrics to adult care, and he's 17 and using it. And our oldest patient that has used it is 102 and have absolutely loved it. Our oldest one at the moment is 93 and religiously does his observations every single day for us. So you can either use the slide or you can just press the arrows at the bottom to put in your blood pressure, your oxygen levels. So we had to get a system that was really, really easy to use because the average age of our patients is about 76. And it was always tell them that we will look at it. Next slide, please. So these are all the self-help guides that we've written ourselves. They did ask us to do videos. We chickened out a little bit, but they are coming. And it has links to support websites like the Heart Foundation, Pumping Marvellous. So patients have access to those at all times. Next one, please. And this is what I see every day. So generally with heart function patients, we're tending to look at trends. So this is us looking at their blood pressure, their SpO2, and where they're sort of alerting green, amber, red. And if it's red, we know we need to get in touch with them as soon as we can. We can either message them or we will contact them and call them into a clinic as needed. Next slide, please. So at any one time, the heart function teams have over 150 patients being monitored. We are aiming to get all 7,000 patients on this. The average time on our caseload has now reduced from anywhere from a year, some of our patients have been on, and now down to 10 weeks. We are fully up titrating our patients on all 4 pillars of heart failure medications within 8 weeks, because now we can do it virtually. We're reducing our clinic appointments. They now have an initial appointment and a discharge appointment. They were needing 8 appointments. They're now needing 2, so it's reduced by 6. No patients on our Docabo and our virtual monitoring services has needed to go into hospital or needed IV furosemide in their homes. We have step up and step down monitoring in place. So as soon as they're seen by me, if I feel they're getting more unwell, I can transfer them up to Wexham or Frimley. Or if I feel they're getting more stable, they go down to a central monitoring service and they will alert back to us if they're at any point worried about the patients. It is a system you can have from diagnosis to death. You can have it as long as you want to. And all patients will have a care plan in place. And this is the feedback that we've got. The information is really easy to understand. Less clinic appointments. Our 17-year-old loves it because it says he can go to school and he doesn't have to think about being ill. He can actually concentrate on being well. It's easier to use. It's built their confidence. They know their numbers and they don't need to take time off work to attend any appointments. And the staff absolutely love it so far. We've been now doing it for about a year and we have now become a comparator site for other sites and a mentor site for other sites. We are currently mentoring Somerset so that they can also get the system in place for their heart function patients. And that's it from me. Thank you very much for listening.
Thank you very much for that, and to all the presenters today. I'll just hand over now to Alex, who will explain how you can post questions.
Thanks, Martin, and with apologies to members of the public viewing this recording, we've had a major access problem. Can only apologise for that, and we will make available a system to post your questions after the meeting once you've had an opportunity to see the recording or just to post questions as you wish. So I thank you for that in advance and for your understanding. Martin, back to you for closing. Thank you.
Thank you very much, Alex. I'm afraid these things do occasionally happen, but you will be able to post questions, as Alex says, on the website when the recording's posted. Thank you again and see you next year.